Good morning. Today was a case to 80 years old woman. She was admitted to our department a few months ago due to exercise chest pain, and after coronary angiography that was made, it revealed multi-vessel disease. And after heart team discussion, we have a decision to treat a patient with stage coronary angioplasty. The main reason for this decision was that also in anamnesis there is a chronic obstructive pulmonary disease.
Why we were fighting with these double bifurcations, one marginal circumflex and second distal left bifurcation, or equivalent of left main. I must say that it was by chance that we started with left, because when we analyzed the situation with cardiac surgeons during our heart team meeting, we believe that we have not so severe situation for LAD, proximal LAD and proximal circumflex artery. Today we faced a situation where that was this progression, so we decided to use IVUS, which was planned for guidance of this circumflex marginal bifurcation treatment, to also assess whether we should do something or not. So that was one point. The second, we believed during this heart team session that regular drug-eluting stents, probably with the usage of two stents technique, will be relatively easy to cover. We were thinking about DK crash, we were thinking about as well TAP. However, today we discovered that this aneurysmatic part of the proximal bifurcation part is significant. There is a progression with circumflex lesion, and then especially with IVUS findings, which showed us a negative remodeling, significant negative remodeling for distal circumflex artery, it made us much more thinking about dedicated bifurcation stent. We have on our shelves BIOS stent. This is a two parts of chromium cobalt stents connected with two struts, taking into account the differences between proximal and distal part of the bifurcation. The difference is in average 0.75 millimeters. Then, based on this information and IVUS data, we decided to change this strategy, not to use main vessel and main branch, but to take a marginal branch as a main branch, other way around, and then to fight with angioplasty balloons to improve distal circumflex artery, and then potentially second stent in TAP technique in case of any problems, dissections and disparagement of flow. There was no deterioration after stent implantation. With IVUS, we really proved that the position is good, that the transitional zone is well opposed in the direction of circumflex artery. And then we started to improve the results, and as you saw, there was no, in certain moments, possibility to use IVUS for guidance. So we, as usually we do, we use enhanced stent techniques, follow the struts of the stent to improve the final results, because we knew from the first and second pullback after the BIOS stent implantation that there was full apposition of the struts. What is very important and to be stressed, that also this aneurysmatic part was fully covered by this proximal part of the bias stent. So finally, provisional T-stenting technique was found as optimal with a TIMI free flow for also for side branch that was circumflex artery chosen in this particular case without proximal dissection towards circumflex orifice, and I'm pretty sure that we really did all we could do with these particular vessels. 80 years a lady with fibrotic and calcific lesions, not well, let's say, responding for any dilatation. So our plan, as far as I know, is just to meet a lady in 3 months to, let's say, to assess whether we can proceed with the next step. So right coronary artery would be the step, but of course, based on control angiography, we can discuss whether we need to leave left coronary artery for this stage or other way around. If we see any progression, we'll again leave right coronary artery, trying to fix the left coronary artery. So I'm pretty happy in 95%. What is your feeling?
Oh, 94.
Thank you very much. Bye-bye.
Thank you. Bye.